Thank you. Thank you. So I've been on therapy for 13 years now, took a year off, and health has pretty much continued to decline over that time. My question is twofold. Number one, what are your opinions or thoughts on moving to the double dose? Number one, is there any data out there that shows double dose is effective? And then number two, any anecdotal experiences with getting insurance to cover the dose?
I'll let people answer that however they want to, one at a time.
I'm going to take this question. I think it's a complex question that you're asking. In fact, what has been shown in preclinical studies is that there is a dose-dependent uptake in muscles. And in infants, we currently apply a higher dose of even 40 mg per kg per week in the infants, and that's also applied in quite some centers in the US, if I'm correct. But it is also really a matter of what you also indicated. We need more data, I think, to show what's best, and especially what is this point is that it's also currently the cost really is something that holds us back, because and there I think I would make a plea also to the industry to see how we can handle this, because indeed if this costs are sky high, we are also blowing up the treatment.
So if I could add to what Dr. van der Ploeg just said, I think there is a growing body of evidence. There are published papers on the impact of an increased dose, and there has been a formal clinical trial which also has shown the benefit of an increased dose on ERT for patients. And so I think the advice is that if you are in a state of clinical plateau or decline, you should reach out to your treating clinician. And in terms of, I know you're from the US, and we do have a system where we can work with insurance and can have it covered. And there has been a benefit, and in fact, we just have a manuscript which describes infants as well as children with late onset Pompe disease, where the impact of an increased dose, so I don't like to call it a double dose or anything, it is what the dose is for that individual that's needed. So there is, I think, data to support this at this time. Of course, we need much more, as Dr. van der Ploeg correctly said.
I just add a very small comment on this as well. So we can't do it in the most states of Europe because just on the cost side. But beyond that, we definitely need a type of clinical trial to really face what we are doing there. Nevertheless, we are already in discussion with companies that they should also think about to move in this direction as well, after this long period of having patients on treatment. And we have facing now really the reality that we see that a lot of them do decline over time, and we have to implement something new for them. So we work on this, and we have to do this all together, industry, patients, and the physicians and the researchers, to really gain ground here.
Oh.
Yes, Pompe is considered an orphan disease, and yet we hear today that there are 20 babies a day that we know of born with Pompe, with a limited amount of testings at birth. If every state and every country tested the babies at birth, what do we speculate the number of Pompe babies a day would be, and how many does it take before you stop being an orphan disease?
I can attempt to answer this. I think there was a definition that was provided about orphan disease status, and even within an orphan disease, you can be ultra-orphan disease, but 1 in 100,000 is the frequency that is considered as an orphan disease. And with newborn screening, definitely the frequency, the understanding has changed. We used to estimate it to be about 1 in 40,000. And now with newborn screening, it's anywhere from 1 in 10,000 to 1 in 25,000. But we have to remind ourselves that not every one of them would be presenting with features of Pompe. They could actually go through life without any features of Pompe disease, because the most common is the leaky IVS mutation that was discussed earlier. And so finding that in homozygosity, where both changes, one from the mother and one from the father, are both IVS, typically does not result in a phenotype. So I don't think that there's any concern that even with identification that we're going to lose that status of it being a rare disease or an orphan disease. It's just enhancing our understanding, I would say, to earlier diagnosis and earlier initiation of treatment, and a better understanding of what the early manifestations of the disease will be.
So I'd like to ask a follow-up question to that, Priya. And this was one of the questions that came across. If it's not strictly mutation, because you may not have a severe enough mutation that even with 2, you'd be symptomatic, how would you diagnose the patient? Do you look at enzyme activity? Do you look at symptom onset? What would y'all look at?
So, Tiffany, this question is coming up a lot in the setting of newborn screening, because as we know that Dr. Reuser showed us there are many, many pathogenic variants or genetic changes that we are seeing in the GAA or the Pompe gene. And with newborn screening, we're actually finding many, many changes that have not been previously identified. And through the classification system as we have it today, through the American College of Medical Genetics, many of these are today called what we call variants of unknown significance. But if you look at the enzyme activity at a biochemical level, there is a reduction in enzyme activity. And so the question mark is that, is there another genetic change that we haven't identified? Or is it that this variant of unknown significance, if we were to do some studies, what we call functional studies outside in the laboratory setting, to prove that it actually is disease causing, is the next step. And this is a way forward. So I think the important part, the message that I want to communicate is that it's not just looking at molecular. Molecular is very important, but sometimes you may not find a second change. But if you have biochemical evidence going back to where we started with low enzyme activity and markers of the disease, that still does make a diagnosis of Pompe disease. It's nice to have confirmation through mutation analysis, but not always do you have 2 confirmed mutations.
May I add a little bit? Because there it's also important which material you use for the diagnosis. For example, the newborn screening cards, the Guthrie cards, are never sufficient to make the final diagnosis. So you always have to add an extra thing, and then you can take leukocytes and do the assay. But if you don't find exactly the clue, then you could use fibroblasts. But in fact, fibroblasts are the best tissue, but it takes longer for the diagnosis because it takes 6 weeks to culture fibroblasts. Then you can measure residual activity, and it gives you a clue whether you are in the patient range or not. What I would also like to point at is that there is the www.pompe variant database.nl, which includes in fact most of the variants that are known currently, and over 400 variants there, so you can look up, is my variant there. But also that there are fuzzes, as you also indicated, variants of unknown significance that we don't know, that may not lead to the disease. That there are also quite a lot of changes in the gene that do not lead to disease. And we have to take care, especially with the high numbers that you also mentioned, that we are not going to treat individuals that will eventually not have Pompe's disease. So that will really be a challenge also for the next future.
Yeah, I also want to add that there's a greater degree of sophistication that's coming about with newborn screening. There are centers in the US, depending on which state is doing it, where on that dried blood spot, they're also able to extract the DNA and actually do mutation analysis right on that dried blood spot. So that's called the second tier testing, which is done. And now additional testing in terms of looking at creatine to creatinine ratio, which is work coming out of Dietrich Matern and Mayo. So there are many, many other ways that are being looked at today of how to make a diagnosis of Pompe disease. So I think the field continues to advance and expand.
Can I add something to this? So I think you have to make a distinction between having mutations that cause Pompe disease, and they are in the database, and you can really prove that they are pathogenic. And then there's something that needs to be done in the coming years, and that is the modifiers. And I think if you identify the modifiers, the genetic modifiers, then you can better predict what will happen with the symptom onset. So what we recently found is at least one modifier that is actually connected to the most common mutation. And if you have that modifier, and then Professor van der Ploeg showed it in a presentation, if you have that modifier, then it's bad news. And if you don't have it, still it can be variable. But this is very important, and it's only one, and there are actually very likely more genetic modifiers. And of course, there's also other environmental factors most likely involved, but at least this is going to be a major task for the future to identify those and to list them. So in newborn screening, you can actually have a better prediction.
There's another question over here. My question for Dr. Krishnani, kind of based on the question before with the ERT treatment. So I'm related to the guy on the end. So if you're on the 20 milligrams per kilogram weekly and you feel like you've plateaued or kind of gone down, do you find going to like a 40 milligram every other week better, or would it be best just to see if you can get 40 milligrams per kilogram weekly?
So I think if I'm understanding your question, is it better to do more at one given infusion, or whether you spread it out as a 20 milligrams per kilogram per week versus 40 milligrams?
Because he's on 20 milligrams
Correct.
per kilogram now,
Correct.
so is it better to go 40 milligrams biweekly?
Correct. So the idea is, we all know that a large part of the enzyme is lost as it's delivered in the liver. And so in the preclinical, and actually even through the clinical trials on alternate dosing, it was seen that if you're able to saturate your receptors and bypass the liver, and you get a better delivery than with the higher initial. So doing 40 milligrams per kilogram every 2 weeks appears to be more beneficial than 20 milligrams per kilogram per week. At least that came through in that clinical trial as well. But I think we need more data. And also there are other factors that have to be considered, when you're doing every week versus every 2 weeks, because it's a longer infusion, and those things. And I know that from the experience across the globe now, doses of even 40 milligrams per kilogram 2 times a week has been done in some children. I'm not proposing that that's the dose, but from a safety perspective, that has been done. But clearly 40 milligrams per kilogram per week has been done throughout the globe on a fairly large number of children, and Dr. van der Ploeg can also speak to that very safely.
Thank you.
We have experience since 2008 in applying a higher dose in infants with Pompe's disease. 40 mg per kg per week is what we supply. And there we definitely show that survival is better and the motor outcome is better in the children. But what I already said, I think this is really a high dose, and also has a lot of consequences for how many enzyme you need and the cost. So we have to be careful there and find more data how to move on in this direction. But definitely there is something we should do. Yeah.
Because there's always this discussion about the costs. But you're not selling a bottle of beer, you're selling a medicine. So if the medicine is not effective enough, you should get more for the same price. And how costly is it to produce it? No one knows. Right? So if we don't know these things, why should we be discussing the costs of a thing we don't know what the costs are? Maybe it doesn't cost anything to give double. No one knows.
Can I comment to your comment? If mannose-6-phosphate receptor is a limiting factor, so then what is the purpose of increasing the dosage? And if we forget about the cost for a second, do you think that giving 100 mg per kilogram would solve the problem?
I have the answer, because we have done all these studies 20 years ago in mice. If you give 5 milligram, you don't reach the cardiac muscle, you don't reach the skeletal muscle. If you give 10 milligrams per kilogram, you do reach the cardiac muscle. You do still not reach the skeletal muscle. If you go up to 40, you're going to reach the skeletal muscle. If you double to 80, you have a better effect. If you go to 100, it's even better. Those are the facts in mice.
Correct. That's the
Never tested, of course, in human beings, but we do know that the kids do far better on the 40 every week than on the 20 every second week. And those are facts. Are they?
Yes, these are facts. And with
all right.
and with respect to the
Just one
mannose-6-phosphate
second,
receptor,
Then would it be fair to say that increase in dosage would be an equivalent of treating them with clenbuterol, for example? So would it balance
It's a very, very good question that you bring up, Nina, and I think that as I think through this, we also do know that there is an understanding that there's a drop-off of receptors as you age, and so the learnings that we have is more from animal models of increased dose. But I do think that if you can upregulate the receptors, that also would be an opportunity. So I think you've got to optimize, because if you've got a lot of enzyme but not much receptor to uptake the enzyme, then it's kind of wasted enzyme. And so I think we do need further work to understand this. And I do believe that there is a role for agents like the small molecules to upregulate receptors for better delivery.
Now, I think there's currently no proof that there is in vivo a saturation of the receptors, because I think the muscles are difficult to reach. So at this moment, there is no evidence there is a saturation of the receptor. Of course, there is a mannose-6-phosphate mediated entry into the muscle. We also know that myosin is not very well equipped with mannose-6-phosphate groups, and that's also the reason why next generation therapies are developed. But still, I think that a higher dose, there's room for a higher dose to reach the muscles and to correct the muscles. Correct.
It is.
Yeah.
No, and
No,
actually, Nina, we do have a paper that we are trying to show the biomarkers, functional assessments, which have shown that there is room. Ans is correct, that there is room for improvement, but I think we're going to reach a limit of how much we can give in terms of how much protein can you give to an individual without any negative or side effects from it as well.
But I have to spill the wine a bit about this. So we have some data, unpublished data in hand. You clearly see with myosin, you have a very nice uptake in the myoblasts. You have a limited uptake in myotubes, and that is saturated. So even if you give high doses of enzymes, you don't get all in. So therefore, the receptor topic is a topic, definitely, and so we need really more scientific work on this really to can say that this is true. But of course, you're right. I think that the trouble in that is that we definitely shouldn't talk about costs. It's more about the scientific base of this.
I don't have this experience, because if you culture myotubes and you add enough enzyme to your culture, you can clean all the glycogen out, for sure. Sure. No point. But there's another point to the dosing that I did not mention.
wait for the microphone, please?
There is the kinetics. An enzyme, a protein, doesn't live forever. It has a so-called half-life, and it decays. And for alpha-glucosidase, we don't know for sure, but it's somewhere between 7 days and 15 days. Now let's say it's 1 week. If you dose 40 milligrams in 1 week time, it's down to 20. So you have lost the 20 simply by decay. If you start dosing with 100, also within the week, you lose 50. So the higher you dose, the more you lose within that week. So it's a rather complicated system, whether you dose high every second week or every fourth week, or lower every one week, and you can calculate very precisely. And with the 40 milligram per kilogram, it doesn't matter whether you give it once every week or once every second week, because the effect is the same. But going to a lower dose, you see differences between the dosing schedules. But that's all theoretical paperwork, you know, it's all calculation, has never been tried.
Okay, so let's go on to the next question. I think it was on that side of the room.
I think it's just sort of been answered whether you said it's if you give infantile onset weekly, would it work the same for late onset? But I think that was just sort of answered, wasn't it?
You mean that if it works for infants, then it should also work for the adults? Is that the point? Yeah. There's reason to assume that a higher dose gives a better uptake in the muscle and also has a better effect. But in fact, we need more evidence to show it in practice. And but I believe that a higher dosage may benefit the patients.
There's another question here.
Thank you. I guess this is mostly for Arnold and Ans and Priya. Arnold, part of the problem, obviously, is that Myozyme doesn't have all the mannose-6-phosphase, I would gather, and that makes probably the problem why it's not uptake properly or enough based on dosage, et cetera, which you guys clearly know the answer to. Many years ago, and hopefully my memory is intact and everything else, both when you and I were younger, I think you, and I don't think Ans was on the paper, that you published a paper that I think you took the native enzyme out of bovine testi, and then you added, which has all the mannose-6-phosphates, et cetera, but however, you then did a dephosphorylation, which then sort of crippled that some portion of the mannose-6-phosphate was not functioning, and yet you saw uptake. So is there other mechanisms that you guys possibly could theorize for uptake of the enzyme that has less mannose-6-phosphates on it, or is that just sort of a pie in the sky and who knows? Sorry to ask that question.
There's not much evidence because we started out with bovine testicles to purify the enzyme from, because we knew from literature that that was loaded with mannose-6-phosphate. That's how it started. And then we tried to take the mannose-6, the phosphate off. We couldn't get it off because we were using the wrong acid phosphatase or whatever. Nowadays there is an acid phosphatase that cleaves it off, so the experiment can be done. What we did in those days, that's 40 years ago, instead of isolating the enzyme from bovine testicles, we isolated it from human placenta. And in the human placenta enzyme, there's no mannose-6-phosphate at all. So we could compare the enzyme with mannose-6-phosphate from the testicles against the enzyme from the human placenta. And the human placenta was not taken up by the cells, and the bovine testis was. That's the only experience.
I can make maybe a remark concerning these two questions about kinetics and mannose-6-phosphate. Perhaps the new protocols will help to answer, because if we consider the Amicus trial, you have a new enzyme which is much more phosphorylated. So maybe we'll have an answer, beginning of answer of how more phosphorylated enzyme can enter the muscle, plus an improved kinetics, because the chaperones improve the kinetics. So the question, very difficult to solve with the myozyme, double dose of myozyme in adults with problem of cost, etc. The answer will come from new trials, in part, no?
In part.
In part.
In part.
Wait.
Because they don't answer the question about a higher dose.
Mm.
But I think there's also a major challenge with delivery. I mean, ultimately it is going through the bloodstream and has to end up in the lysosomes in the muscle. And so you also have to make sure that the delivery system is able to deliver it. And so if you've got patients who have cold extremities or poor circulation, it is difficult and challenging to get the enzyme to that. And so we have to think of different aspects for this disease. I think we are looking at mannose-6-phosphate, that's great. We also have to look at glycogen synthase, can we reduce the substrate? We have to also look at autophagic flux as a mechanism. We've got to think of mitochondrial aspects. So I still think that it is multifaceted, and this is one way and one aspect that we are putting a lot of energy in, but we have to consider other aspects of the pathophysiology of this disease. And Nina, would really appreciate your comments on this. That's you.
I guess it's something about the blood supply. The blood supply, because you want?
No.
If you don't want. The blood supply, because the volume of the vessels, what you can do to get more enzyme through the vessels to the muscles. Someone told me, he was in sports physics or whatever, that you really have to exercise very, very, very hard before that has an effect at all. So you have to, I don't know, run a marathon or be weightlifting for an hour, and only then you have an effect of a better blood flow that could significantly improve the the enzyme going to the muscles, and otherwise just by moving a little bit. He said no chance. I don't know. I have no idea.
No, that's the whole point, that we're not delivering completely efficiently, because you're usually you can't be running a marathon to get the enzyme, right?
I have no idea.
No
one has ever measured delivery.
Exactly, but I think those are unanswered areas.
Yeah.
Good name.
I think you are talking about the delivery to the lysosome.
Yes,
Once
that's what I mean.
the enzyme is already in the cell.
Correct.
Yeah,
Correct.
and
That's
then all the pathological changes in muscle, including the non-contractile autophagic buildup, certainly interferes with the proper delivery to the lysosomes.
Exactly.
I kind of just want to piggyback off of that question. When we're getting our infusion, if we're just kind of sitting getting it, is that worse for you than if we were to be moving around? And then kind of secondly to that, I've heard that you shouldn't eat while you're getting your infusion, but mine spans across 8 hours, so I get hungry.
Yeah.
So I can answer you from the really first cohort we looked at this, and there was clear. So it was presented very nicely. A few of them, and they still do exercise. So they sit on a bike and whatever they can do, or even if one is going on the treadmill and is doing a lot of this, and they clear have, for them, they think that this is stabilizing them. But we haven't really a proof of concept for this, honestly. So this is really a few patients, they still do it. Others have tried it, have not seen things. So there were even patients went on a vibration platform, something else you could do and think of. There was not a real big change in the long-term outcome measures we've seen so far. But I think it's worthwhile to do, because you have to do something in those hours. So use the time for training.
Yeah.
So
it won't
that's
so
perfect. Why
so
not?
I think really training is of course good to do. So if you can use the infusion time for training, that's of course advisable. But we have also tried to, because we also had the idea to increase the blood flow, and in the beginning we also had the patients on ergometers and do training, but at the end we didn't have the idea that it really made a difference during the infusions. So there is still research to be done, and but training in general, I think it's really good to have it as a supportive measure besides your enzyme replacement therapy.
But warming up the body, I think, is really something you should consider, so that you are not on a skin temperature of 32 degrees or less than that. So that makes really sense. So so room temperatures should be given, and you should be really warm, and that will help for the distribution of the enzyme.
But then, Benedict, it also goes to the superficial vessels, and you need the deep vessels to reach your muscles. Well, so there is also...
But the hope is really...
Do you eat, do you not eat? Because then the blood goes to the stomach and not... Yeah. Just
our patients eat during the infusion.
Yes. It's a long time, and you should eat something.
Yeah, we've actually done the study. So in 2012, we did acute and chronic training where we provided the Myozyme 1 hour before they started exercising. And we know clearly when you run mice at 15 meters per minute, there's a huge increase in delivery to the muscle. I mean, it's unequivocal. It's without question that there is a massive increase in delivery. And yet, both acutely and over a period of training of 3 months, we didn't see any effect whatsoever. Much to my surprise, because it has been shown multiple times that there's an increase in capillarization with chronic training, which on its own would increase delivery. And clearly, acutely, there's a massive increase in delivery to muscle. So I was very surprised that it did not work. Enz has a good point, too, is that you get a huge diversion to the skin when you're in a hot environment. So probably not the best thing to do when you're exercising. If you want maximal relative delivery to the muscle, it should be in a neutral environment or slightly cool.
It's room temperature.
Yeah.
2012, yeah.
There are more questions on this side. So, do you still have the question?
Hi, it's me again. This is on a completely different aspect, like the complete reverse. I'm actually having to read because it's not my question. I'm asking this on behalf of another POMPS patient. The POMP patient was diagnosed 5 years ago, started treatment, everything was going very well, and after 2.5 years of treatment, started allergic reactions. Was stopped treatment for 6 months while the doctors tried to ascertain what was going on, restarted the treatment, and the allergic reactions continue. The family would like your advice on what to do next.
So there are many approaches to this in terms of the allergic reaction. First is understanding the cause for this allergic reaction, and so one can do testing in terms of looking at IgE, which is another kind of antibody which can provoke an allergic response like to a bee sting. Also looking at complement and looking at tryptase, and these kits are available through the sponsor Genzyme. So first trying to understand what is resulting in this reaction, and then dealing with it based on the findings there. And then I think there are many approaches where you can pre-medicate, but also you can change the rate of the infusion up to the point of when that reaction occurred. And many of us have published on this, not just in Pompe, but in other therapeutic protein arenas where you can successfully desensitize. So there really shouldn't be a reason why a patient is discontinued due to an allergic reaction. There should be an ability to work with the allergist and also with treating physicians to be able to treat these patients.
Mostly, we also succeed to continue infusion, and especially in infants. And what's very important, to decrease the rate of the infusion in the beginning of the infusion. So that's important to have not an allergic reaction later on. So especially that's important. And to provide antihistamines and corticosteroids. But although I have doubts how much it really influences the reactions. And in some instances, there's really very difficult to counteract the allergic reactions. We rarely encounter that in infants. We always succeed to manage it in a way, but in some adults, there we had to stop the treatment. So to give a good advice, I think you really need to know the circumstances and do it step by step, as we discussed.
Yes, I can do another comment because it's a very difficult point to manage indeed in adults, because there is a lack of guidelines. When you read the literature, there are very few papers with guidelines for retreatment of the adults. And in France, we are currently working on collecting the data for this patient with a reintroduction of treatment. For some of them, we needed to continue very low rate of infusion during hours and hours. So this is also a matter of organization, because you modify from 4 hours infusion to 10 hours. So it's very heavy for everybody, for the patient and for the nurse. And in addition, again, each center is doing its own cooking. And I think we need also to have international guidelines for readministration of treatment. This is an important point.
Dr. Laforêt, je vous remercie. Je vous pose la question de la part d'un patient français. So if you could give me that treatment center, I could return the information back, because I'm speaking from the Association Francophone Glycogéneuse.
Yes, but I hope he could reach me in France, because there is a problem of communication. But no problem.
I'm sorry, I have a follow-up question about the bovine testicle study. My wife has done a study with Dr. Jones, respiratory therapy, and I know for a fact that it was a struggle at times to have enough people in the study. My question is, what exactly did you have to say to that bovine to get him to decide to join that study?
Thank you. There's only one in the room who can answer this. This is
It's foreign to the human body. So if you would use that, you would have, I don't know, an enormous immune response. Now it wouldn't work. You can take it from urine, though. That's a very good form of alpha-glucosidase, but there's very little in it. So that takes 100 liter a day. We did that too in the past. But 100 liter, you end up with 1 milligram. And in one infusion, you get 200 or something. So
that is undoable, yeah. In fact, that was one of the reasons to further develop enzyme replacement therapy with recombinant human alpha-glucosidase, because you really need a recombinant human enzyme to have sufficient amount for the patients.
Okay.
Hi, so Sean from Detroit, Michigan. Not really necessarily a question, but when we were talking about the allergic reaction, I was kind of unique because pretty much from my 4th infusion on from Lumizyme, I'd try and sleep during my infusion in between work, and I'd wake up with rigors, sometimes have a fever. That was with, Tylenol and Benadryl, and I'm on ITI now, about 2 months in, and we tried everything. We tried doing steroids. We tried slowing down the infusion before ITI. Nothing was working. I mean, it was slowed down like crazy. It was like 8-hour infusion. And I mean, now I can finally have an infusion again. I never had any allergic markers. I had high sustained antibodies. So I don't know if you've seen that before with allergic reaction tied with the antibodies, but that seems to be it. We haven't gotten the blood work back yet with antibodies, but despite reacting to the rituximab the first time too, everything, I can sleep right through it. So
how high are your antibodies?
I want to say 52, 55,000.
Okay. Yeah, 51,200.
Okay.
There we go.
Yeah. And so
I know you'd know.
So I think the interesting part here to remember is that in patients who have these high sustained antibody titers, if you go back and see, many of them also do have an allergic kind of response. And I think that with very high IgG, you're sometimes masking your IgE level, so you're not really able to measure it. But also the CRIM negative, or the ones who are mounting that kind of high IgG antibody titers, are also the most likely to recognize the infused enzyme as a foreign protein, so you can have a reaction to it. But again, the point is that I hope that you do well, so please do keep us posted on how this goes. But again, the message is that one does need to work with immunologists, when you're dealing with these titers, because just pre-treating with Benadryl, it's again like putting Band-Aid on a big wound without knowing what is resulting in that reaction. And if you understand the mechanism of it, then you can pre-treat accordingly and not just mask the reaction, but rather get to the bottom of it and prevent it from occurring again.
I just had a question, and I know in some of the studies I've read that they've talked about rapamycin being beneficial in clearing glycogen from muscles in mice. Do you think we're at all close to that with humans in any sense? And then my second is, what are your thoughts on mTOR in terms of clearing out glycogen from the muscles and stuff like that?
This is also a complex question, because the machinery in cells is very complex, and there are very many enzyme pathways that interact with each other, and mTOR is one of these. And in fact, the idea behind rapamycin is that it reduces the influx of glycogen to the lysosome. So in fact, you need to have enzyme in the lysosome to have an effect, because otherwise you can't degrade the glycogen that's in the lysosome. In fact, we have some experience with rapamycin, but not because of the fact that we wanted to use rapamycin, but because we used sirolimus, that's rapamycin, also in some patients for secondary immunomodulation. And there, I don't know. I don't know that it's not a significant effect, but of course more studies need to be done to know it. But it's not something that it's the miracle drug that you should use.
So in the gene therapy trials, you will see that. So in the SPARK trial, there is sirolimus included for different action point here, of course, but we will learn about this.
So I can say about the rapamycin question, like when we look into the mTOR activity in the mouse, the activity is already down in the knockout. So rapamycin is an inhibitor of mTOR. So I don't think so there is any added effect of the rapamycin. And even where we are trying to bring back the mTOR so it can regulate the autophagy, and so there is no effect of rapamycin. I don't think so there is any point to use the rapamycin as a drug.
Thank you. I'm gonna, I think, ask one of the last questions, and it's for all of you to answer. You've all devoted your professional careers and lives to helping Pompe patients. We're sitting here today, 20 years after the first successful trials for Pompe started, 24 years after the AMDA was started, 20 years after the IPA was founded. We've seen a lot in these years. There is a commercially approved therapy, and tomorrow we will hear about next generation therapies, both ERT, gene therapy, and others. Where do you see us in the next 10 years or 20 years? Where do you think the current research is taking us, and where do you hope it's taking us?
What I hope, I truly hope that in 10 years we have cured the disease. Of course, that's the spot on the horizon, that we want to cure the disease. But we also have to be realistic, and that's what we've learned from the past. I think we also need to be very happy that we have a treatment for Pompe's disease. I think Pompe's disease, if it comes to neuromuscular disorders, is really in the lead. And all other neuromuscular disorders follow, for example, now SMA, and they will be confronted potentially with the same problems that we see with Pompe's disease. And I always compare it with, for example, the treatments for leukemia, that the first treatment were not successful, and when you continue and take what you learned from the previous step and continuously use that to improve it for the next step, then we come somewhere. I really hope that we come up with a very good treatment. I hope that first, I think the first step is apply the treatment that we have in the most proper way and do it as good as possible. And then with that knowledge, also think about the next generation enzyme replacement therapies. And then we, of course, are on the verge of having the AAV gene therapy, for example. But there also we need to realize that we are confronted with the same problems as with enzyme replacement therapy. Of course, there you have a constant source of enzyme. You're going to infect the liver. The liver is going to be a kind of enzyme source for continuous distribution of ERT throughout the body and to as a continuous source for your other tissues. But again, the muscles need to take up the enzyme, so that we need to find out. The first tests in the mice are okay, but we have to see also what happens in the humans. And then, of course, there are the AONs. We'll hear about it tomorrow, so maybe I go too quickly. But that's a different approach, where we try to increase the production in the cells of the patients. So that is a potentially a complementary approach. And then there are also developments with lentiviral gene therapy, where the bone marrow cells are transfected, and these cells are then functioning as a kind of enzyme therapy source. And there, the possible advantage is that these cells can also cross the blood-brain barrier, and that might be an option for children with Pompe's disease. But of course, and that's the happy thing. There are a lot of new developments, there are a lot of thoughts, and there are really a lot of people currently working, and industries wanting to develop these therapies. So for patients, I think it's very, very important. But first, we have to see whether it works in the patients. And we are all in. We want to try.
So thank you, Hans, for that. My only added comment is that I think similar to what we have learned from leukemia and other conditions, it's not necessarily going to be just one therapy. It may be a multiple or a multi-pronged approach to treatment. I definitely do feel that gene therapy is on the horizon and is the wave of the future. But I think in addition to that, there are going to be other adjunctive therapies that are going to be needed. And so I think for now, the goal really is to stay as healthy as possible and to do the best we can today, so that we have the chance of the next set of therapies, whatever they turn out to be. But there's definitely a lot on the horizon now. So I think the future is very bright.
So to my turn, I would say that I'm also very optimistic for sure. The negative point probably is the difficulty to target the lysosome, because since so many years we have difficulties to understand the pathophysiology of this disease, and we see the difficulty to target inside the cell the lysosome. But the other point is that there is no examples, I think, of neuromuscular disorder with so many clinical trials, with so many possibilities, from enzyme therapy to gene therapy to oligonucleotides, etc. So I think that for a disease with so many possibilities of treatment, we should be optimistic, but realistic also.
Right, so what can I add? I can add something, a more perspective on this. So I definitely, I talked about this or asked for this morning, preventive treatment. So if we have newborn screening in place and have the diagnosis within 2 or 3 days after life, after birth, so then we should already have something in hand that really prevents completely the disease. So that is really my hope within the next 10 to 15 years. And that will be hopefully a non-viral gene replacement. That is really my hope for the infants. For the adults, I think we need all what we ever can get We need for every person of you something very individualized. So we will have gene therapy on top of this. You will still receive enzyme, so it will be combinations of things. You will have other small molecules on top of this, really to prevent the whole cascade, and that has to be very individualized. And then hopefully we are very close to a cure for some of the patients. But not for all. For some it will be very hard. And think about something else, perhaps that's my final comment. Beyond all the biological things, the first thing you should get rid of the next 10 to 15 years is the wheelchair. So we will start to develop things about so-called exoskeleton. So that's something we really will substitute some of the wheelchairs with exoskeletons. I think that is really a step in between, beyond all biological treatments we will have. We need new thoughts on this, and you yourself could explore this and should help to explore this.
Thank you, and I think speaking on behalf of the patients, we're all very excited to see what the next 10, 20 years bring us, and I think what we've seen is that we work best together, and when we work together, we've made the best things happen. So we're very eager to continue partnering and working with everybody in this room to really push things as far as the stars. Oh. Okay, we got 1 minute, so a very short question.
I'm absolutely 100% fan of all the research and all that you've all done to help Pompe disease. What I'd like to know is how can we stop the case-by-case battle to get more people to collaborate with you, with us, to help the research? Why are we still fighting case-by-case, country-by-country? How can we as patients be advocates to get further people into whatever treatment is going to happen? We know that not everybody is treated. We know there's still cases one by one that we have to fight for. How can we help you? Please, let us know.
Yeah. What I can say is that indeed, I think a meeting like this is already very important. And I think what has made the Pompe field strong over the years is that we have done it together and always been in line together. What I experienced myself is that indeed it's quite some effort to get it all done, because you're stumbling on the regulators and really it's almost sometimes a day effort to get things done. And by doing it together, and I think therefore it's also very important to have this IPA meeting, we can reach much more than on our own. So please, it's not an answer, but I think continue to collaborate and continue to work together, and let's see where are the unmet needs and how can we help together with IPA. I think that's the main point.
Sorry, but I have a provocative answer. In France, the public hospital is in very bad health. So, of course, we need the patient, and we will continue the collaboration. But in a few weeks, there will be a big strike. It's difficult to do strike in public hospital, but in Paris, it's a big concern. Every day we have a meeting to decide how we can change this problem, because we lack of nurses. We have a lot of units that close. So doing research in France in the public hospital is every day more and more difficult because of the administrative problem, because of the economic problem. So it's extremely crucial at this moment. So if you can help to defend the public system in France, thank you very much.
Thank you all.
I just want to end on one note, is that all of us have been here for several years, so clearly we need that next generation of clinicians and scientists to take on from where we have started. And I think all of us are doing our best to encourage that next generation, but maybe at the next AMDA meeting, Tiffany, we should have a session with young blood, to encourage them and have a showcasing of the talent that is maybe way better and brighter than us.
Thank you.